Welcome to the Anatomy and Physiology section of the Hepatobiliary Ultrasound online training module. I am Rico Estrella and I will walk you through this course. In this section, we will review the anatomy of the gallbladder, biliary tract, liver, and adjacent structures, including the duodenum, hepatic artery, and portal vein. And I will give you pointers on how they correlate to ultrasound imaging. Biliary ultrasound has benefited greatly the past couple of decades from technological advancements in ultrasound machines. Biliary tree ultrasound is safe and easily performed without radiation. It is cheap and widely available in most hospitals and diagnostic facilities in the Philippines. Ultrasound also opens up possibilities in image-guided biopsies and other intervention. As we all know, the gallbladder is a sac-like structure located in a fossa along the undersurface of the right lobe of the liver. The biliary tract runs between the liver and the duodenum. The gallbladder is divided into three sections: the fundus, the body, and the neck. The fundus is rounded and projects below the inferior margin of the liver. Here, the gallbladder is in contact with the anterior abdominal wall, approximately at the 9th ICS. The body is in contact with the liver bed. The neck is the most superior part of the gallbladder and is contiguous with the cystic duct. As general surgeons, we are very familiar with this, but do take into consideration the differences in how these structures lie in the non-operative setting. The neck is directed posteromedially towards the porta hepatis, which contains the portal vein, hepatic artery, and common hepatic duct. The cystic duct joins the common hepatic duct to form the common bile duct, which in turn empties into the ampulla. Do take note that the distal common bile duct runs behind the duodenum, which can be a factor in its visibility. The gallbladder's size and dimensions can be quite variable, but generally 7 to 10 centimeters long, with a diameter of 2.5 to 4 centimeters in the normal individual. Wall thickness normally is 2.2 to 3 millimeters. Anything greater would be considered thickened and could indicate gallbladder edema from inflammation or ascites. Typically, the gallbladder would contain around 50 cc of bile. Take note that in the supine position, the gallbladder is obliquely oriented in reference to the sagittal and transverse planes. Wide variability is the rule when it comes to gallbladder position in patients. The neck of the gallbladder is usually fixed at the main lobar fissure, but the body and the fundus of the gallbladder can be loosely affixed to the mesentery, which results in positional variability. Intraoperative anatomy is a bit different from the anatomy you see during ultrasound. Typically, in a patient lying supine, the fundus is inferior and the neck is superior. The gallbladder often assumes an oblique orientation with respect to the sagittal plane. Also, the size and shape of the gallbladder is very dependent on the amount of bile it contains. This is the reason why we ask patients to fast for at least 6 to 8 hours, ideally, when we want to image the gallbladder. To review, bile produced by the liver initially enters the bile canaliculi and goes into progressively bigger bile ducts, later on draining into the extrahepatic ducts. The common hepatic duct courses medially and caudally, running parallel along the anterior margin of the portal vein. This is the reason why the easily seen portal vein usually serves as a landmark in locating the common bile duct. The common hepatic duct, the CBD, typically measures less than 8 millimeters in the adult Filipino, usually 4 to 6. Anything bigger should alert you to a possible distal obstruction. The cystic duct is an S-shaped structure and joins the common hepatic duct to form the common bile duct. Just to repeat my earlier statement, the common hepatic duct and the common bile duct both travel parallel to the portal vein, and thus the portal vein serves as a consistent, easy to find landmark for normally sized CBD identification. However, in cases wherein the CBD is dilated, this may cause some confusion. The first portion of the CBD lies within the free edge of the lesser omentum, cephalad to the duodenum. The second portion of the CBD, however, lies posterior to the first portion of the duodenum, and the gas contained in the duodenum often makes this portion of the CBD hard to see during ultrasound. Thus, you often see hepatobiliary tree ultrasound reports that state the distal CBD could not be seen due to overlying gas. The third portion of the CBD sits in a groove behind the pancreatic head. The normal common bile duct and common hepatic duct usually measures 4 to 6 millimeters in adults. However, it is important to take note that in patients older than 60, the CBD is usually wider, approximately 1 millimeter wider for every decade about 60. Also, in patients who have had a cholecystectomy, the bile duct takes on sort of a bile storage role and may normally reach 10 millimeters in diameter. These factors have to be taken in consideration when interpreting bile duct diameters. The anatomic relationships between the common bile duct, portal vein, and hepatic artery is very important to identify these structures correctly. The proximal common bile duct lies anterior to the portal vein and lateral to the common hepatic artery proper. The more distal CBD travels behind the duodenum and behind the pancreatic head before emptying into the ampulla. Within classical anatomic liver lobules, bile ducts and branches of the portal vein and hepatic artery travel together within collagenous sheets known as portal triads. These branches coalesce into the hepatic artery, the portal vein, and the common hepatic duct at the porta hepatis. The common hepatic duct subsequently unites with the cystic duct to form the common bile duct. The common hepatic artery, the portal vein, and the common bile duct course along in close proximity as they exit the liver. This anatomical association is used to identify the common bile duct during sonography. The common bile duct lies anterior to the portal vein and lateral to the hepatic artery. As noted previously, the common hepatic duct also sits anterior to the portal vein and is commonly misinterpreted as the common bile duct. The common bile duct is located slightly lateral and more tightly coupled to the portal vein as compared to the common hepatic duct when viewed with ultrasound. The liver continuously produces up to 800 to 1,500 cc of bile per day in the typical Filipino adult. Hepatic and biliary ducts transport bile directly to the duodenum or indirectly via the gallbladder. The gallbladder's primary role is to store and concentrate and release bile when needed. Bile normally flows down to the biliary tract, ending at the common bile duct. In fasting states, the sphincter of Oda is closed, preventing bile from entering the duodenum. As bile production continues, pressure rises within the common bile duct, and bile then flows into the gallbladder via the cystic duct for storage. Bile contained in the gallbladder is subject to the epithelial lining of the gallbladder lumen, which resorb water and electrolytes. Thus, bile within the gallbladder is typically more concentrated than what is found within the common bile duct. Also important to take note is that the gallbladder is non-essential for life. Without it, like in patients who have had cholecystectomy, the biliary tract delivers bile directly to the duodenum. Bile is composed of water, bile salts, phospholipids, and emulsifying agents which are necessary for fat digestion and absorption. Bile also contains bile pigments formed from heme metabolism and cholesterol. Bile release into the intestine serves as a method for excretion of cholesterol that the body does not need. Bile pigments lend bile its greenish color and are metabolized in the intestine by bacteria, which gives stool its brown color. Bile salts undergo enterohepatic circulation. Once bile is released into the intestine, it eventually travels to the terminal ileum, where most of the bile salts are absorbed into the intestine's capillary beds. From there, it travels to the venous system, where it re-enters the liver via the portal vein. Once in the liver, it is absorbed by the hepatocytes, which then release it back to the biliary ductal system. The release of bile from the gallbladder and biliary tract is triggered by fatty acids and proteins entering the duodenum from the stomach. These substances are detected by the duodenum, causing specialized endocrine cells within the small intestine to release cholecystokinin, otherwise known as CCK, into the bloodstream, and it travels to its target organs. Cholecystokinin causes the following effects. It stimulates the liver to synthesize more bile. It stimulates the gallbladder to contract, the sphincter of Oddi to relax, and it is the primary stimulus for release of pancreatic digestive enzymes. As the gallbladder contracts, bile is propelled out of it through the CBD and ampulla and into the duodenum. When the concentration of fatty acids and amino acids declines in the duodenum, CCK concentrations decrease, which causes the ampullary sphincter to contract and the gallbladder to relax, causing bile to be stored once again. This concludes our review of liver and biliary system anatomy and physiology. You may now proceed to the section of sonographic anatomy of the gallbladder and biliary system.